Today I'm going to, so shall I start?
Yes, please. We can
Yes,
see
please go
your
ahead.
screen.
Yep.
Yes. Good evening, everyone. Today I'm going to present my topic on pathophysiology of persistent pulmonary hypertension. As we know, there is after the birth there are certain vascular changes. There is a transitional phase, and certain pulmonary, especially in the pulmonary vasculature, certain changes occurs after birth. So at birth, fetal pulmonary circulation rapidly adapts to the direct blood flow to the lungs. So this will leads to rapid decrease in the pulmonary vascular resistance, leads to the redirection of the half of the blood to the lungs from the placenta, as well as there will be increase in the systemic vascular resistance, which is in response to a surge of catecholamines post-birth, as well as the removal of the placenta, which is a low pressure area. So this the following diagram, it depicts how the changes occurs post birth. So as soon as the gush of air goes into the lungs, the lung liquid is replaced with the air. There will be pulmonary vasodilatation, which will leads to decrease in the pulmonary vascular resistance, and there will be decrease in the right ventricular afterload, as well as there will be increase in the pulmonary blood flow and increase in the pulmonary venous return to the left side of the heart, that is left atrium through pulmonary veins. So this will lead to increase in the pulmonary left atrial pressures, which will lead to the functional closure of the PFO, as well as we can see on the at the bottom of the diagram, as the low resistance placental circulation is cut off, there will be increase in the systemic vascular resistance, which will lead to increase in the afterload, and because of the increase in the afterload or SVR, there will be functional closure of ductus arteriosus, and there will be also increase in the myocardial compliance because the heart has to pump against the resistance, so myocardial capacity of the heart will also increase. So coming to the next slide, this shows how the transitions occur before and after the birth. Basically the pulmonary arterial transition. So in the left of the diagram, this is before birth. You can see the endothelial cells are tall and they are swollen, and the smooth muscle layer is the muscular layer is also contains smooth muscle cells, which are multi-layered. On the right of the diagram, this is post-birth. After the birth, when there will be there will be changes in the circulation of the pulmonary side. So the arteries, the endothelial cells becomes flattened, as well as the smooth muscle cells. Also, there will be spreading of the smooth muscle cells. So depending upon this change, there will be the change in the pulmonary circulation after the birth. So coming to the topic of pathophysiology of PPHN, pathophysiology of PPHN can be discussed under three headings. First is the pulmonary vasculature. As I explained in the previous, pulmonary vascular remodeling is the pathognomic of PPHN. In babies with PPHN, pulmonary vascular transition is not successful, resulting in high PVR. In such cases, pulmonary vasculature demonstrates increase in the muscularization of the pulmonary arteries, which are non-muscular intra-acinar arteries, and peripheral extension of the vascular smooth muscle cell layer. So, first thing is the muscularization of the pulmonary artery will occur, and secondly there will be the extension of the vascular smooth muscle layer. So this is the first thing which occurs in the PPHN. So second is at the level of the lungs, PPHN is classified as secondary when there is associated lung disease such as meconium aspiration syndrome, pneumonia, sepsis, TTM, CDH. These all will lead to severe pulmonary vasoconstriction. That is because of the neural or humoral vasoactive substances which contributes to this vasoconstriction, which and these are either platelet activation factors or production of arachidonic metabolites. There will be also decrease in the nitrous oxide, prostacyclin, bradykinin production, which basically does the vasodilatation of the pulmonary vessels in when they are physiologically present in a body. If there is no underlying lung disease and PPHN is due to vascular changes, it is called as the primary idiopathic or black lung PPHN. So absence of lung disease and less vascularity makes the lungs black on chest X-ray. So if this is the primary or idiopathic or black lung PPHN, so there will be decrease in the vascularity, and we can see the lungs will appear black on X-ray. Then the cardiac changes. The third is the cardiac changes. There will be cardiac changes in the PPHN, which are because of the extrapulmonary shunting of the blood, which occurs because of the right to left shunting or the bidirectional shunting, which occurs at the level of PFO or at the level of PDA due to high pulmonary pressures. Now, the PPHN results in both right ventricular dysfunction and left ventricular dysfunction. So, elevated pulmonary artery pressures can result in right ventricular hypertrophy, tricuspid regurgitation, bowing of the interventricular septum to the left. In this diagram, because of the increase in the pulmonary vascular resistance, then the systemic vascular resistance or the pressures are suprasystemic, so the tricuspid regurgitation will occur. There will be the bowing of the left interventricular septum towards left. There will be shunting of the blood from the right atrium to the left through the PFO as well as through the PDA. It can be bidirectional as well, depending upon the pressures. And these can be found, this we can find it out on the echo, these findings. So depending upon the cause, depending upon the cause of PPHN, we can divide the PPHN into 4 types. One is the poor adaptation secondary to the lung disease. This is maladaptation, which occurs usually during RDS, meconium, aspiration syndrome, pneumonias. Then there will be remodeling of the pulmonary vasculature with normal parenchyma, also known as idiopathic or the black lung. This is because of the maldevelopment. Third is the hypoplasia vasculature, which we usually see in cases of pulmonary hypoplasia, which occurs either in CDH, oligohydramnia secondary to the kidney diseases, or leakage of amniotic fluid, that is under development. And third is the obstruction, which occurs because of the polycythemia, hyperviscosity, leading to the intravascular sludging and elevated pulmonary vascular resistance. Thank you.